Hello, and welcome to the training, Things I Wish My Therapist Knew. I am Suzanne Kearns, and I'm a clinical psychologist and one of the co-developers of this training. In the following presentation, we will walk through a number of important considerations of children and youth who are in the foster care system. As you know, there are sometimes challenges with coordinating therapeutic treatments with the rhythm of the child welfare system. We will provide an overview of the child welfare system and some of the timelines a case needs to meet. We include some thoughts about how your role as a mental health therapist may be helpful as a case nears certain child welfare specific benchmarks. Some of the unique situations of children and youth in care may potentially compromise a therapist's ability to follow a treatment model. We will walk through several examples of these unique needs and how they can be interwoven within the treatment to provide holistic support. Importantly, you will hear directly from individuals who represent critical perspectives for this training, both in recorded videos and as speakers. We want to acknowledge and highlight how these perspectives reflect the importance of common factors in treatment, including therapeutic alliance and building trust. We know from research that both relationship factors and the content of treatment are both essential for relief from mental health symptoms. This presentation is designed to highlight the balance between these two perspectives and hopefully provide some critical insights about how to include biological families and/or foster parents in treatment. Like any training, we feel that we just scratched the surface of many of these issues. We hope this provides some food for thought as you continue your dedicated work with these children, youth, and families.
This training was developed as part of a grant called Creating Connections, and I'd like to acknowledge the grant as well as several of the collaborators who've helped inform components of the training over time. One thing to start out with for this training is the title, and we picked this title based on information that we got from young people, alumni of care, who had been through the child welfare system and also had experiences with the mental health system as well. They provided lots of insights about their experiences with the mental health system, and we've recorded some of those in the following video. This video, we walked through several different perspectives, not just of young people, but also of their caregivers and their biological family.
The most helpful has been my latest therapist, and she definitely talks to me as if I'm an equal, as if everything that I say is relevant, and that she is very understanding to my needs, and definitely willing to listen to everything, my insights, my thoughts, and she definitely works with me to really address the things that I want to work on. So.
What was most helpful while my kids were in child welfare was that we participated in mental health counseling together, but each of us, like my daughter had her counselor and I could participate in counseling with her, and then my son had his own counselor and I got to participate in counseling with him. So there wasn't like competition for us to have my time divided with each of them during the counseling session. And then when we were ready to have joint family counseling, we were able to, as a family, participate in family counseling.
So as a parent who was going through the child welfare system, as well as the mental health and chemical dependency system, the most helpful piece for me was having a therapist, case manager, or whomever was providing those direct services, having the ability to identify the appropriate services that I needed, and communicating that back to the child protection social worker, advocating for me and what they believed was helpful, and just staying in consistent communication with them, rather than just generating reports.
The biggest thing is if the mental health worker is someone that will speak with you, correspond with you, so that you can let them know what's going on during the week, any of the problems that you're having at whatever particular time it is. Most of my kids do have therapists, not all of them want to do it. So it's really helpful if I can work with that therapist. So many of my kids have attachment disorder problems, and they've been, in several placements, as many as 50. So for them to understand how the foster system works and understand what that does to kids, and the trauma, I think that's probably those are the people that we're most successful with.
I think, like, once you get a counselor that you like, and like they switch all the time, like they always leave, and that kind of sucked. And then like just being put on medication and saying that I have this and this issue, it was ridiculous. Like they put me, and I didn't need them. Like when I went to that lady, she took me off of all of them, and I was fine. It's just I needed somebody that could actually make me feel comfortable enough to talk about the issues that I was having.
I didn't need something to fix me. I needed something to help me process what was going on. I had a therapist who tried to give me these tactics that they didn't really help me move on. They didn't really help me give the people I needed to give forgiveness. It didn't really help me. It didn't help me move on. And I think that it was because it didn't really get to the root of the issue. I felt like a lot of times it was just trying to fix as opposed to help me understand.
Nobody taking you seriously when you tell them that you have some challenging behaviors with your kids, or they believe you but they don't know the extent of it, kind of thing. So, because I really didn't know that my kids had these challenges when I got them back, and they just became progressively worse.
Really, for me, it was identifying services that were, I would say, surface issues. So the drug addiction treatment, which underneath that needed to be mental health services focused on trauma that I had survived. So I feel like it would have been more helpful had somebody been able to recognize those signs, behaviors, and symptoms as a trauma response rather than behavior that was drug addictive.
Going into a facility, a treatment provider's facility, to get a child enrolled in mental health services and having them do an assessment, an invasive assessment, and waiting in a lobby where there's adults that are having nervous breakdowns and shouting and yelling, and I think it's really important to keep the youth and the adults teams completely separate from each other at all times.
I think for young people who are coming from the system, whether they are currently or used to be in care, is really being able to have counselors and therapists who have a background in populations that have experienced any sort of trauma, whether it's abuse or neglect. I think it's really important that young people not only have a place to be able to discuss their feelings and life circumstances and situations, but they have someone there who's able to help process them and who also has the background to understand what they're going through and experiencing, and to have someone who's there to help normalize their experiences.
If people had looked at me in a more strength-based manner rather than just me as my behaviors and identifying me as that, what I did, it would have been a very much of a difference in my life. Later on that did happen, but early on at such a young age, having been so traumatized and not knowing any coping skills, I believe if somebody had utilized and drawn out my strengths, it would have been very beneficial for me.
And they're like, well, you can't come in. And I was like, why? And they said, because he's 13 now and he gets to make all his therapy decisions. And I was totally in shock that they said that in front of him. I wish that somebody could have warned me or kind of give me a heads up that this was the law, and maybe took me to the side and talked to me a little bit about it. Maybe I could have been aware, had a little conversation one-on-one with my son, and try to make that decision together so he could move forward.
When I have good therapists, they will find different ways to work with the child. They will get a hold of me and say, did that work this week? You know, how did it go? Did you do what just following up? And I think that these are things that if they would actually reach out and have a little more time with us, the best workers that I've had have been able to get down on the kids' level and really understand what's going on.
Working with foster youth, I would probably say, like, treat them like they're normal. Like, I mean, yeah, we're foster youth, but at the same time, like, we just want to be normal. So it'd be like if you had a normal kid coming into therapy, like, I had a couple of counselors treat me like I was the problem, and like what I was doing was why I wasn't, you know, in my home situation. So that was kind of frustrating, and they always called me, oh, foster youth. Like, I'm a person, that's not who I am, and I wanted to be labeled as Katie, not a foster youth. That's not all I am. So that was frustrating.
So children in foster care, they come with a unique set of issues, trauma, different things that have happened. If therapists could really just sit down and go through the child's story, make their notes so that they're refreshed each time that child comes in, and then talk with the foster parent. It's really important, even especially with our teens, that they don't just shut down. And a lot of us foster parents, we've got the ability to help out.
For therapists moving forward, really orientate yourself and educate yourself on the child welfare process, the acronyms and what it means and what it is like for a family or a youth going through that system. It's very challenging. There are a lot of hoops to jump through on top of whatever else that has led them into your office. I think it's really important for you to know that, because we are sometimes just learning how to navigate that system ourselves, and it makes it much more challenging to trust the person who is providing services to us if they don't know how to navigate that system, how to advocate effectively for that person.
Recommendations. I believe in the team approach and the collaboration of all parties, agencies, professionals. I really like where we can all sit down at the same table and talk about our same goals moving forward. You know, I like professionals that can come to court, you know, and advocate, or I love professionals that can sit at school meetings, you know, pertaining to the child. I just believe that the bigger, the better team approach we have, the better end goal we can reach.
Okay. We hope that you enjoyed that video and that it sparked some interest and ideas for as we move through the rest of this training. At this point, I'd like to turn things over to Barb Putnam, the Children's Administration, to talk with you about Child Welfare 101.
Hi, everyone. This is Barb Putnam with Children's Administration in DSHS, Washington State. I've had an intrinsic role in working with Sue on developing the training, and just want to step forward and give you all information about the child welfare system. So child welfare has three basic pillars of our system, and they are safety, permanency, and well-being. And mental health needs of children all fit in with each one of these core set of services. So the thought that in safety that we're dealing with mental health issues of the child as well as the parent, it plays into how well the child does as we work towards permanency, whether the child's going to be able to go back home and be with their parent. And well-being is the last cog. So we really want to take a look at and address the needs of kids across the full spectrum, and that's in addressing their mental health needs as well.
All right, so this next slide shows some data about children and youth that are in Washington State and some of the mental health needs that are observed for those that are in the child welfare system. So we pulled some data from fiscal year 2015, and what we found was that 62% of those children that were between the ages of 3 and 17 on the screening tools that were administered had some sort of mental health concern that was noted. So this means that about 2 out of 3 young people in the child welfare system have a possible or likely concern as it relates to mental health needs. When we looked at those children more closely, we saw of those who had a need indicated, about 65%, so again, about 2/3, had received some sort of mental health service within a year of entering the child welfare system. We also saw that about 33% of those young people were diagnosed with some sort of mental health concern prior to coming into the system, and about 16% were prescribed a psychotropic medication within 1 year after entry. So this gives us an indication that children and youth that are in the child welfare system have a high level of mental health needs, and those needs are being picked up by the mental health system and the healthcare system respectively.
This slide is a depiction of how many kids in a year's period of time are coming into the child welfare system, just to give you an overview of the kind of numbers and the processes that child welfare has to go through as a child welfare intervention system in the state of Washington. So, you know, in the year, and this is a calendar year, in 2016, we really received over 111,000 phone calls, requests for intervention. From that, we have a lot of legal mandates that tells us who we can go out and visit and see whether they're, and do analysis and assess whether there's abuse and neglect. And so that number is smaller. And then from there, then there's a determination that is made. I'm going down the triangle in how many kids are screened in, you know, which tells us then really there is something going on that we need to address. From there, we have a dual pathway from investigations, which you're all probably aware of that programming, and FAR, which is our kind of prevention, early intervention program that's available in the state, and then open for services, which means they're coming into foster care. So out of that large pool of over 111,000, about 18,000 kids came into care, and then from there, about 6,114 kids were placed. So open for services could be, you know, we found a family that the child can live with. We've done a safety plan. There's all sorts of different ranges of programming that helps. And at the same time, there's exits from the system. So we're not only having kids come in, but in the child welfare program, we also have kids that are working towards whatever their permanent plan is. And you can see the large number of reunifications. Some kids end up in adoptions. There's a group of kids that go to guardianships. And then there's actually a group of kids that age out. So I kind of talked about some of the programming in this slide, but it is how the system works. CPS intake is the way to come into the system, and if there is an allegation and it is a proven allegation, and we take dependency, then you come into child welfare services, and from there you either go home or the different pathways that we talked about. Adoption is the big program. Our voluntary services are on the right-hand side, which is the FAR Family Assessment Response. 2 other kind of coupled voluntary programs where a family can just call in and get some help would be the Family Voluntary Services and the Family Reconciliation Services. Those are services we offer to kids and families in their own home. So this is a closer look at the CPS responses. CPS has 2 distinct programs underneath what we call CPS, which is a typical program that you're all very aware of, which is the investigation side of CPS and child welfare services. And that's stayed the same relatively the same over time. The new program that we have in the CPS response is the Family Assessment Response, or FAR. You may have all heard about that. This actually is a program that helps keep children in their home. It does work with the parents. It is different than a CPS response because it doesn't have an investigation, but it does work with the family that looks like that they're at risk. There is some non-emergent neglect or some low to moderate physical abuse that's been going on, but they are assessed as if they have some supports, a family under stress and duress, if the family had some supports and services, that they really could safely care for the child in the home. And so there is a short-term intervention. They do an assessment. It's like up to 3 months of services that that are offered that help support the child and family in the home. And that's also something that we offer here in Children's. So this slide actually just kind of walks you through the court dependency court process time, and we placed it in this training because we think in the mental health sector there's a lot of confusion around social workers going to court and what does that mean and what is their timeline. There are federal overarching federal mandates that really direct child welfare work, and this dependency court timeline really does tell you when the social worker has to go to court in relationship to the case. And what we'd like you all to think about is that you have a role in, if you're treating a child in child welfare, of working with the social worker around, they have to do a court report, and they have to send that to the court, and they talk about all the services and how well the child is doing in the services in each one of these hearings. So the dependency is in the first 72 to 30-day period, but every 6 months is a rhythm that you probably need to be aware of, is every 6 months they're going back to court to have a conversation with the judge about the progress of the child. So this slide just is an overarching some of the activities and programs that we do inside child welfare. We do have an overarching Adoption and Safe Families Act, which was enacted from Congress in 1997, which puts that timeline in. It also, the court timeline, it also dictates that if a parent doesn't comply with what the plan is within 15 months of the case opening, then it mandates that we move to termination of parental rights. And I know from the mental health side, that can be problematic if you don't understand that there is actually a law that is directing kind of our activities as a child is in child welfare services. We do look at reunification, adoption, guardianship, permanent legal custody, and just Washington State is one of the best states in the country that looks for relatives to actually place the child with relatives rather than move them into foster care or stranger care. So about 47% of our kids that come into care actually end up with relatives. We also have some programs for adolescents, the responsible living skills and emancipation.
Okay, thank you, Barb, for that wonderful information about the child welfare system in general. One of the interesting things about the interface between the child welfare system and the mental health system is that sometimes the timelines and rhythm and structure of the child welfare system don't always match on to our treatment plans or ideas for a particular program or practice. Additionally, we've heard from mental health providers and child welfare practitioners across the state about some confusion about where and how different roles can help mutually inform each other's work. So one thing that we looked at is where there is very tangible spaces for mental health providers to be included within the child welfare system's roles and progress. And so in the beginning, when a child first or family first has an open child welfare case and or are first placed into foster care, it's likely that there'll be a lot of questions to mental health practitioners about a treatment plan for that young person. It's possible that you might be invited to participate in a family team decision-making meeting or shared planning meeting in which some discussion may be happening about how to best support that young person while they're in care. During the middle part of a child welfare case, it's oftentimes either it may be that the child welfare professional is just learning about a mental health need, and so your treatment might be earlier, or it may be that you're also in the middle of your treatment as well. But at that point, you're addressing the clinical concerns in treatment, and it's likely that your child welfare counterpart will be very interested to hear about progress that's being made, potentially having an opportunity for you to weigh in on impact placement changes or that kind of thing on treatment progress so that good plans can be made to ensure continuity of services and care for the young person. Later in the child welfare case, oftentimes we're looking at reunifying with biological families or supporting permanency placements that might be arranged either with adoption by a current foster parent or adoption by a new family. And so although that may or may not be something that was explicitly part of a treatment plan, say for anxiety or disruptive behavior plans, the impact of that type of permanency decision on treatment is important to evaluate. And we have a banner at the bottom of this slide that says, consider how to involve caregivers and biological parents throughout the whole process. We're going to switch gears in this training now to talk about some skill applications, and we're going to hear from both Jamerica and Danielle about some very tangible ideas about how to involve caregivers in this process as well. So as we move to this section of the training, we're going to start by having a presentation, a video of some perspectives from alumni of care as well. Hopefully you'll hear some more in-depth discussions about their experiences with the mental health system. And then we're turning it over to Jamerica to talk to us some more about young people's perspectives within the mental health system.
I wish that they had listened to me. I wish that I was actually seen as a person and not a file or just a subject of therapy. I wanted them to kind of talk to me as a person. And I also wanted someone to make it seem like I'm not a freak. am not damaged or anything like that, because a lot of what I experienced was that those therapists would kind of treat me like I was damaged, or I was not normal.
I wish that I would have been asked by, like, what is it that I want? What is my goal in this? Like, if I'm going to go to therapy, what is my goal for it? Do I even know why I'm here? Asking those kind of questions actually help you understand why you're even going in the first place. A lot of it was confusing because I was in care and I was trying to understand what the situations were and trying to learn how to advocate myself, and how, like, what is going on is the most confusing thing, is that when you're young and you have no idea why you're placed in a different home and nobody wants to talk to you and tell you the actual truth, and you know you're being lied to, that is the hard part. So why would you talk to another person if you don't even know why you're there in the first place?
My recommendation for therapists that are going to be working with youth coming out of the foster care system or the child welfare system would really be to meet them where they're at. Come to where they are, understand that they may have never had an opportunity to start working through some of this stuff, and to try to tell them what's wrong without really understanding what's wrong can be more harmful than helpful. And that's what happened with me, and I really wish someone would have really not tried to do the traditional method and really tried to think outside of the box, because these issues really are outside of the box, and it's a different population that you're working with.
Hi, my name is Jamerica Haynes. I'm the Alumni of Care Communication Specialist, and my role with the grant is to help with communication activities, whether that's helping with the newsletter or presenting during this training. Right now, you are looking at the Things I Wish My Therapist Knew survey results, and I was able to interview about 12 members of Passionate Action, which is a youth advisory board to Children's Administration. And what I was able to do was ask these young adults what their experiences were like in foster care, as well as particularly what it was like receiving mental health services. And the majority of them, I would say about 95% of them, did receive mental health services, and the majority of them said they did find it helpful. They were able to talk about some of the barriers they experienced, as well as other activities they felt provided an all-around holistic approach to healing and being able to cope and process their experiences while in care. A little bit about myself: I was in care for about 8 years of my life, and it wasn't until I reached adulthood that I was able to receive counseling regarding what I had experienced. And what I felt was helpful was open communication, namely being able to understand what counseling was, what my role in that process was as well, not just going and having a counselor tell me what to do, but having an opportunity to talk about my hopes and dreams, as well as my fears, and just also being able to have someone else serve as a sounding board, as a means for me to process and cope with past situations, as well as my day-to-day life. And that was a really great experience, just being able to have that open experience of communication with my counselor, because that really helped me be able to move forward with my life. Another opportunity that I saw that really made my experience with counseling good was collaboration, being able to work with other people who were able to refer me to different services outside of counseling that were essential to my well-being, whether that was activities like going to the gym, going to church. I found that this was really a holistic process as far as just being able to understand what happened, but also to having an opportunity to develop a life where I was living and not just simply existing. And then also too, just being able to have my counselor work with my health practitioner just really made me feel supported with having that wraparound support. And then another thing too is just being able to give young people in care a sense of control when it comes to receiving mental health services. And what I mean by that, just allowing them the opportunity to speak what's on their mind, allowing them to ask questions, and then also to just allowing them to be themselves. I think that's important, just knowing that they don't have to say a certain thing, or if they don't want to do counseling, hearing that young person out so that they don't feel like they have to do something that they don't want to do, and just being able to hear their concerns and really just get to the bottom of what they're feeling. And on our next slide, we have the culture of foster care. And this was created by the Foster Care Alumni of America. And these postcards represent the various experiences that alumni in care experience, as well as those who are currently in foster care. And with this slide, we really just have an opportunity to look at these postcards and ask, just consider the self-talk they might engage in, you know. No one loves me. I feel alone. I don't understand what's going on. And just the role that you can do is just really, like I said, just being able to be open ears and really hear out the young person. I think they have a lot to deal with. And I think especially for young people and especially kids, they don't really have that life experience yet to compare to when it comes to dealing with difficult situations. So I think it's really important to not only hear them out, but also give them strategies to help them cope with the situation. I think this is a really great opportunity to also include the people in the foster child's life, whether that's foster parents, biological family members, even the social worker, when at appropriate, just being able to collaborate with them and find out what's happening with the child. And then also to just being able to, when necessary and when appropriate, just have that child feel like others are included in their life in therapy and counseling. That way they don't feel like they're by themselves or this is a process they have to do alone. Thank you so much for listening and hope you enjoy this training.
So we want to dovetail from what Jamerica and the youth have just talked about. So we'd like to join with the mental health folks about the LGBTQ considerations for all the kids that we jointly share. And this is some of the awareness that child welfare is coming into at this point in time. And so we'd just like to talk through a little bit that, for child welfare at this point, we're being very cautious about the use of pronouns and names that we use for the LGBTQ identified youth. And one of our concerns is that maybe a youth may be identifying to the therapist, but they're not to child welfare, which just to remind you that no one, unless the youth says that it's okay to talk about it, then we're not. Then we can't cross over and talk with each other about those issues. And by the same token, the child may have identified to the child welfare and not to the therapist. So that's just something about holding the youth's rights to have their own voice in their own life. So we're moving towards feeling more comfortable in asking youth questions and seeing how they are identifying themselves. And I think that this part of the field is going to grow over time.
Similar to what Barb was just talking about, there's also cultural considerations that are specific not just specific to the child welfare system. However, when you have a young person that's in a home that is not their home of origin, sometimes the cultural considerations are particularly complex. And so a few ideas are noted on the slide here, but it is possible that our young people find themselves in living situations where the cultural traditions and approaches in particular families are very different than those in which they grew up. And so although that may or may not be part of a particular treatment approach for a particular problem, we know that this has impacts on our young people's development and their understanding of their place in the world and all of those things. And so the point of this slide is to encourage the discussion about different cultural considerations that a young person might be experiencing, even things like different norms and ideas around food. It could be apparently subtle, but be something that has a big impact on that young person. One thing that is helpful, and now we're switching gears again, but we wanted to give some insight into psychotropic medication prescriptions for young people that are in the foster care system. And although you as mental health practitioners and your child welfare counterparts share that neither are the prescribers for the psychotropic medications, both of you are in important positions to try to identify and advocate for appropriate usages of the psychotropic medications. This is particularly important because we know that children and youth who are in the foster care system are prescribed medications at a higher rate than average, and they're also often prescribed multiple medications that we aren't confident in the long-term efficacy of the approaches. And so having many people with eyes on the role that medications might be playing in young people is important. So this slide is a good news, bad news slide. So the good news is that Washington State does tend to perform a bit better than other states, particularly in this study that was done that's on the slide, in both prescriptions for antipsychotic medications as well as mental health drugs in general. But when we compare foster youth to non-foster care involved youth who are also on Medicaid, we do see rates of psychotropic medication use quite a lot higher than we might expect. And so while we're doing better than average, we still have a ways to go. And the more people who have eyes on this idea are asking these questions and are advocating is really important.
And to dovetail, we also know that that there's confusion, not only in the child welfare field, but in the mental health side, about what the policy is, the child welfare policy is around psychotropic medications. And so this slide just really highlights that really the consenter is really the biological parent. And if the parent is unavailable, then the social worker is able to consent. And we always, that goes in through the court. So there's a court order to prescribe and to use psychotropic meds. And we're all bound and understand if the youth is 13 and over, then they have to consent, and we're all in agreement about that. That's an easier piece. And then anybody over 13 has the right to confidentiality of all of their information. And that's on the child welfare side as well as on the mental health side. The piece that's not on this slide is that if the child is actually legally free, meaning that they're headed towards adoption, then the social worker is the consenter. And again, the age 13 and over would apply.
We know that involving families in treatment is associated with better outcomes for children and youth. And it's helpful to think about, strategies for involving caregivers in treatment in general. For children and youth who are in the foster care system, this can be extra complicated for mental health practitioners to figure out, since it's not just the foster families, it's also the biological families. So we're going to turn over to Danielle now, who's going to talk with you about some perspectives of biological caregivers, parents, and then we'll have an opportunity to talk about some tangible ways to incorporate biological families into treatment.
Hello, my name is Danielle Goodwin. I'm the parent ally and voice for the Creating Connections presentation. I'm a mother of 5 and also a successfully reunified parent of children who experience foster care. I am a survivor of exploitation as a young adult, and while I was a youth, I had also spent time in foster care, which is where my firstborn daughter was born at age 16. It's important that we continue to learn how to engage parents, and I'm passionate about doing so in order to reduce the harm to children and unnecessary time in foster care whenever possible. So I'm currently the service manager for a behavioral health organization in Seattle, Washington, and have been doing this work for over 6 years now. I'm trained in trauma-informed care and have had many opportunities to use my experience to shape policy and practice in both child welfare and laws that impact poverty-stricken communities, including those where youth are at risk for sex trafficking. Today, I'm going to share the parent perspective on involving biological parents in therapy. So involving biological parents early on in the child's therapy is essentially crucial, and even more so when and if there's a reunification plan, and there almost always is. By involving the bio parent, you, the therapist, will gain more information. You'll start to build that relationship of trust with the biological parent, which is a much needed component moving forward. The fostering of relationships with the foster parent and bio parent is in the best interest of the child. And that way we're all working toward one common goal, and that everyone actually ends up being on the same page. One of the things I've found in my own experiences, as well as in the work that I've done, is that all too often parents are left in the dark about issues their child is facing, any type of behaviors, and seem to find out during court sessions or hearings. And that's unfortunate. The behaviors, therapy goals, and all of that are a great opportunity for us to share and educate the biological parents that are engaged in visits with their children. If parents are not aware of how they can do or say certain things that can be supporting their child during visits, they will either undo the work you're doing, confuse the child, and or feel out of the loop and only hear how they are detrimental to the child when visitation reports are negative. This will just increase their shame, which is something biological parents deal with. Myself and other parents that I've worked with also have often felt like if they had known better ways to communicate with their child about what was going on or how to say things in a more therapeutic way, so that when their child is asking questions, they can have meaningful ways of answering those questions without doing it wrong. The kind of questions that I'm talking about that children have when they're visiting their biological parents and are during the foster system are usually about coming home, or why am I in foster care, or I miss you. And a lot of it has to deal with focusing on how they deal with departure of visits and making it less traumatic for both the child and the parent. Just imagine having to say goodbye to your child each week, several times a week, and enduring the crying and uncertainty of if you will see each other again. How do we know as parents that it's critical for the child to feel validated in their feelings that they are experiencing, including being angry at the parent? if we were never taught these skills ourselves. We are often the result of poor parenting, and unless we are coached and taught that, we sadly repeat the same parenting patterns. So these critical things can definitely be pre-planned. Parents can be supported, understood, and taught how to discuss those topics with their child's feelings in mind, and so that they feel validated and not ignored. Ideally, the therapist can start to engage the parent before the parent engages in these unhelpful ways, like saying things like I did, yes, you'll be home soon, or, you'll be home, and giving them a date. For the child, soon might easily mean tomorrow, or think that it's the next visit, which can only lead to a disastrous goodbye again. For my situation, the lesson that helped shift visitation reports and empowered me to ask, how am I doing? Are there ways that I need to improve? Eventually helped me learn that I was giving more attention to one child than the other. And that allowed me a safe area to make those mistakes, be vulnerable, and explore other areas I could be more attentive. Had I not had a provider give me that gentle, trauma-informed feedback after gaining my trust and working to build trust with me, I may not have reunified, and I most likely would have allowed those negative reports and assumptions and opinions about me to lead me to shame and isolation. Ultimately, our family benefited from being reunified because one success was built on another. And until I was able to become the parent I am today, and I'm still continuing to become even better as each day passes. So bio parents and foster parents, caregivers, involvement, participation, and collaboration in treatment together can make all the difference for a child, especially when the child is receiving behavioral treatment. My hope is that if bio and foster parents are communicating with each other, even if it's through notes or letters, it can make all the difference for the child or children. Bio parents are often vilified in this process, so being mindful of how including them will likely improve engagement and participation is critical. Some parents will need more time to earn your trust, and that might mean that you, the therapist, are slowly building on that trust and communication. Be patient and just know that you're breaking through possibly generations of mistrustful relationships with systems and that parent. Maybe at first it's giving the mom and dad updates before even involving them in the sessions and asking their thoughts about what the child's behavior is and some of the things that are being worked on in therapy. That gives them opportunity to share their thoughts, and even including them in sessions and eventually in the long term will be wonderful for the child and parent long term. We want to essentially build a supportive relationship so the parents after reunification see that therapy and support ongoing may even be something they desire, and in turn will reduce chances of returning to the foster care system. Providing parents with parent peer support is another effective evidence-based intervention that I've seen increase the likelihood of success for all involved. One thing to consider, especially if a child is in behavioral health treatment, to plan for transition early on from working with foster parents on parenting skills and all the wonderful things that we do to ensure that foster parents understand the child's behaviors, is to transfer that over to the bio parent, giving them the same attention and knowledge, trying to ensure that you, the therapist, put as much energy and even more to the bio parent so that they can use those skills and knowledge during and after reunification. Knowing this beforehand is helpful for you, and it may inform how you approach them. Yeah, it will look different than the way you've engaged the foster parent. Mental health services for bio parents is another important reason to engage them. In my opinion, we can all benefit from mental health therapy or services, and this would be a great time to start to discuss what that looks like. We often will provide peer support and refer parents to our groups where I work at the agency when their children are either in foster care or in therapy, and work indirectly with them. And then as we build that trust and they learn that a parent peer also has been through similar experiences, and we share how and why mental health services have helped us when we were in the same situation, opens the door for exploration of engaging in those types of services. Peers, parent partners, parent allies are all a reflection of recovery and hope. So that's why they are so effective at getting parents and people to see that mental health services is a benefit for them, and it also empowers them to engage in the critical services that they need. Now I would like to discuss some of the barriers that biological parents face, and some of them obviously you might be aware of, but transportation, housing are two big barriers that parents face because they are essentially working a full-time job, going to visitation several times a week, court hearings. Often they'll have to go to treatment and take urinalysis tests. On top of that, they most likely will have a job and have other activities that they need to maintain their housing if they already have it, or searching for that type of housing and resources. So having that in mind with scheduling and such is really important, and what type of resources would be needed for those parents can also make a big difference. One of the things I like to share with parents who are starting to have supervised visitation with their children is to prepare them that although they don't have their children with them, it's critical that they access resources that can give them free diapers and supplies for their visit if that's needed. Always healthy snacks and certain things that the visit supervisor will be looking for. And we do a lot of education around. They are essentially showing the department and the visit supervisor that they are an effective parent and that they can provide. Sadly, myself included, it has been too many times that parents go into visits expecting that the diapers and the snacks and all of the supplies will be provided because they are with the child, and the foster parent may have been sending them previously, and one day they don't, and so the parent is left there with no diapers and once again feeling shameful and neglectful. So especially when planning visitation, to go over these types of things with parents prior to their experience so that they feel empowered that they are able to show up and support their children. And that will also prevent a poor parent report and the shame and isolation and guilt, maybe even avoiding visits so that they don't have to endure that court hearing about hearing how they failed again. All of those things are really important to keep in mind, and sometimes parents have experienced them. So I always like to remind people that parents do the best they can with what they have. And if parents don't have much, they aren't going to be able to do much. So once we provide the support, coaching, and resources, then we continue to build that trust, and the parents and children will thrive. That's why we do the work that we do. Thank you so much, and I really appreciate the opportunity to share my experience and knowledge with you, and I hope that this training has been beneficial.
So thank you, Danielle, for that. On this next slide, what we have are just some ideas about what you can do as a mental health practitioner for involving biological families and caregivers in treatment. Danielle already mentioned a number of the different ideas that are on this slide, and no doubt you have other ideas yourself as well. Thinking about how we understand the role of biological families, how we tell them about the types of treatment that their children are receiving, problem solving logistical issues with getting to treatment and participating in the sessions, being flexible and thinking about different ways that that we might involve caregivers that have limited ability to attend, such as those families who might have a parent who's incarcerated. It's really important to think about and partner with your child welfare collaborator on what is possible and how do we best involve caregivers in treatment. So one of the things that we were challenged to do as part of this training is to think about what are the really unique features of children and youth that are in foster care that's different than typical children and youth that you might see on your caseload that aren't in foster care. So we spent some time thinking about some of the unique circumstances that these young people find themselves in, and wanted to offer some ideas on how to incorporate these unique features into treatment. So for example, children and youth in foster care often have visits with their biological families, whether it's sibling visits or with their parents. It's very common for youth to have challenges around these visits and to have caregivers report that the behaviors are changed or altered either in anticipation of a visit or right when they get home. And we know a lot of times you're already working with the young people on their coping skills and emotion regulation. And so being able to help coach our young people to be able to use some of those skills as it relates specifically to visits may be very helpful. We also know that there may be just some simple strategies for reducing distress altogether that might be helpful in talking with biological parents and foster parents about as well to hopefully prevent some of those situations from occurring. It's often tempting to try to reduce visits when there's behavioral problems that come up, but it really could be something that could be a focus of clinical intervention. Another example of this on this slide is transitions. Young people that are in the foster care setting often experience placement changes, or they have to go to respite care for periods of time. And it's not uncommon for young people to have negative self-talk associated with some of these transitions. For example, they may say things to themselves like, it's all my fault, or if only I was, better behaved, I wouldn't have to go to respite, those types of things. And so it can be really helpful in this case to really assess what the children's perceptions are about respite, and when inaccurate or unhelpful thoughts are there and present, to provide psychoeducation around those things. You can also review with foster parents what messages are given when they're placing a child into respite care to make sure that those messages are positive and don't contribute accidentally, unintentionally to some of those negative self-thoughts. The next unique feature for children and youth in foster care is court participation. We know that some children and youth may be actively involved with court proceedings. They may be required to testify about experiences that they've had. And regardless of their amount of involvement, any sort of court participation can be experienced as anxiety-provoking. So this, again, is another place where partnering with your child welfare counterparts is important to know about when these court hearings are happening. This is another example of where the coping skills can be utilized specifically to help with particular situations. It may also be helpful to discuss different court procedures and who makes different decisions about things. We've heard from many alumni of CARE that they felt a little left out or uncertain about what was happening to them and not sure about what these different procedures were like. And oftentimes your child welfare counterpart may have a lot of information about that you might find helpful if the young person's asking you questions during the session. Finally, we have permanency plans on this slide, and similar to what I was just saying about court participation, a lot of times young people find the permanency plan to be confusing. As Barb had mentioned earlier in her Child Welfare 101 introduction, oftentimes there's concurrent planning that's happening at this same time. We're both planning for permanency and reunification at the same time. and so a young person might get mixed messages about what to expect. Also, those that go into open adoptions may end up having some level of contact with biological family members, and this may be something that needs specific attention to ensure that it's in a healthy way for everybody involved. So our recommendations here again is to partner with your child welfare counterparts, and whenever possible, involving a biological caregiver in treatment that will help enhance that reunification piece, or in the case of open adoptions, a really healthy ongoing relationship. And so work closely with your child welfare counterparts to ensure that there's appropriate levels of continued parental involvement. Next up, we have visits with siblings. We know that some children and youth want to visit with their siblings while they're in care. There is a effort that's made to have children placed together with their siblings, but of course, for practical reasons, sometimes legal reasons as well, that's not always possible. So again, similar to visitations with biological family members, really coordinating and understanding what those visits are looking like, what the schedule looks like, but probably most importantly, you as mental health practitioners may hear about grief and loss that's attached with some of these visits, and you are in a unique position to both help the child cope with these types of situations, as well as let social workers know, because there may be opportunities to increase visitation or alter it in some way to make it more healthy. And there may not be, but having that conversation can be really helpful and important. And this is also the case with visits with other important relationships. It's not uncommon that children and youth in foster care may have challenges keeping in touch with other people who are important in their lives, but sometimes there are creative solutions around that as well. So as you hear concerns, or you hear young people really wanting to keep different relationships and maybe have some concern about placement disruptions and the impact that that could have on those relationships, this again is another very supportive place that you can join with a child welfare professional in supporting the needs of that young person. We wanted to spend a little bit of time too. We know that a lot of the children and youth that are in foster care are receiving trauma-specific treatment from practitioners in the field. And we also know many of you in Washington State have been trained specifically in trauma-focused cognitive behavioral therapy and/or CBT+. And so one of the things that we worked really closely with Lucy Berliner on as part of this training is thinking about how does routine trauma treatment interface with the foster care experience? And so wanted to provide you with a few ideas about how when you're doing your trauma-informed care, you can incorporate that features of being in foster care into that. So this first slide is probably very similar to what you're already doing in thinking about trauma and trauma-related services for the children and youth that are in your care. We know, though, that children and youth that are in foster care are disproportionately likely to have experiences of trauma. So applying that lens to the work that we do can be really important. We do know that children in foster care have multiple exposures to trauma, and that it's also, we have heard that that caregivers don't always have training in how to manage trauma. So, for example, spending a little bit of time with a foster parent who has a newly placed child and talking with them about what they could do if a child brings up a trauma-related experience or seems to have behaviors that might indicate that they're having a trigger related to a traumatic event could be really helpful in supporting that caregiver to have a healthy response. When you're doing TFCBT, an example of where you can embed some strategies for addressing the unique needs of children and youth in foster care within the trauma treatment are listed on this slide. So we have psychoeducation. So in addition to providing psychoeducation about trauma and the impact of trauma, you can also consider adding an element where you provide helpful information regarding the child's welfare services, what their service plan is, and permanency. When you're working on parenting, it could also be the case where you're looking at proactive ways to include biological parents in that parenting component, increasing empathy for the children and what they've been through, and teaching parenting skills specifically for unification is the permanency plan. When you're working on the prac skills and the coping in particular, and we already mentioned this earlier, as you're going through specific coping skills, applying those to child welfare related stressors such as visits and court hearings can be a way to help generalize those coping skills, not just to their traumatic experiences, but also to their child welfare experiences. When you're doing a trauma narrative with a young person, it could be important to include within that narrative experiences with the initial and ongoing placement into care, especially if the trauma was the precipitating event for placement into care. And then finally, with the conjoint treatment, preparing foster and biological parents both for conjoint sessions when possible. And this could include the young person talking directly about the impact of placement and the placement experiences, and not just the trauma within those sessions as well. So Barb and I are going to conclude by doing a little question and answer across the child welfare and mental health system. So my first question is for you, Barb. What can I, as a mental health practitioner, share with child welfare system?
Most normally there should be a consent in place. So that's either come over with the intake signed by the social worker, the bio parent, or some court order that says that we can talk if the child's 13 and over and has signed consent. Then anything and everything we can work on together, which is really what we're trying, which is the ideal in this situation.
Well, what information would be helpful for me to share with the social worker?
There's 2 or 3 things that I think are really important. One is initially we're encouraging social workers to come into the intake so that the clinician has the most up-to-date and from some historical perspective what's going on with the child and is involved from the beginning with the treatment plan. If that's not possible, then there is hopefully communication going on back and forth about the need for the referral and what the concerns are. After that, child welfare, that court report that we talked about every 6 months, it's important to understand what the treatment plan is. The social worker is actually checking with the youth and the caregiver every 30 days. They can actually support the treatment plan, talk with them about working on, whatever you're working on. And then it's that 6-month piece, some kind of a report, even if it's over the phone, about progress made so that they understand not only what medications the kid's on, if he or she is on medication, but the progress in treatment kind of in general so that they can report that to the court.
So as a mental health provider, how can I be involved in what's happening with their child welfare case?
Hopefully from the beginning with the release of information and the consents at the very beginning. I know that the schedules between the busyness of mental health clinicians and the pressures there and child welfare don't always match up. But we are hopeful that you figure out a pathway with each individual child and caseworker to have that a monthly check-in phone call, or involve them in kind of the progress, the treatment and the progress as it moves along. Child welfare is really working towards a permanent plan, and within the context of the permanent plan, you know, just their abilities to cope, what you're seeing as their triggers, you know, so that the social worker can cross over and not only work with the bio parent and reinforce the things that you're seeing and things that need to happen, but with the caregiver as well. So it really should be, and we're hopeful that it is, some kind of a teamed approach.
And what do you think is some information that child welfare workers might have that could uniquely help me in my job as a mental health therapist? What might be important questions for me to ask?
So we do have a court report that we send every 6 months, and that might be helpful to you. When a case is early in the first 30 days when a child is coming into child welfare, we do have a systematic assessment process, or a screening process, which is called the Child Health and Education Track. From that is we use validated screening tools, the PSC 17 and the SCARED, and for the little ones we use the ASQSE, and to really take a look at what are the mental health needs, which helps guide our case planning to send for a referral. That is available. We do send that report to the caregiver. They are allowed, and they can share it with you. Many of them may be doing that already, but you could ask the social worker for that document. It's a point in time in the first 30 days of a kid coming into care. So it does give you a baseline, no matter when you're seeing the child in their life in child welfare.
That's great. It sounds like there are just so many benefits to close collaboration on both sides that mental health practitioners are uniquely positioned to provide helpful information to the child welfare professional and vice versa. And so it seems like having that that capacity to collaborate and be able to maximize the resources that are available across each system is really important. We'd like to give a special thanks to our team, and also especially the children, youth, and families who've helped inform the direction of this training. And if you would like to get any further information from myself, Barb, Jamerica, or Danielle, you can see our contact information below.